Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect podcast. I'm Dan Carter. We're here at Countryside Equine Hospital, Treatment Room 1, what we call our studio. Got a special guest today. Got Dr. Meg Green from Equine Vet. How are you doing this morning, Meg?
I'm good. How are you, Dr. Carter?
Fantastic. So today's a pretty exciting episode because Meg is not just a technical services vet, but she is a friend of mine. We actually interned together at Rood & Riddle. I don't want to tell her age, but that was 15 years ago.
Yes.
Yeah, 15 years. So we interned at Rood & Riddle together. We both practiced equine med for a while. Of course, I'm still here. Meg went on to bigger and better. She spent a lot of her career as a technical services veterinarian. We'll talk a little bit about that, but it's a really cool position. They provide a lot of support for veterinarians in the field, and we could not do our job without them. So one of the cool things about today is we get to talk about one of my favorite topics, which is joint health. We get to talk about joint health. We get to talk about osteoarthritis. And we also get to talk about a really cool product that I'm really excited about, and that's Arthramid.
Excellent. Well, thank you for having me today. I'm excited to get the opportunity to speak about it as well and really hopefully be able to change some mindsets when it comes to the treatment of OA and how doctors are going about doing it.
So let's talk a little bit for our listeners. We actually did a podcast a few months ago, and it had to do a lot with osteoarthritis and joints.
Okay.
We kind of went through some basics, but I kind of want to start. Let's do a quick review about what all's going on in a joint. So when you go to your vet and they say your horse has arthritis, to me as a joint nerd, I will fully admit I'm a joint nerd. When you say osteoarthritis, that's the same thing to me as saying you're sick. Like, we really haven't said anything yet. Mm-hmm. There's a lot that goes into osteoarthritis. So let's kind of do a quick review, and let's go through for the listeners, and let's talk a little bit about, what makes a joint, and then what's, where the real issues are in a joint. Because to truly understand this product, I think you got to understand why this joint, where arthritis comes from.
Absolutely. So I think when you think about it, we go back to the basics. And so when you look at a synovial joint, there's some key structures that are there within the joint. And one of the key structures that really serves its purpose as far as nourishment and keeping the joint healthy is a structure called the synovial lining. And that synovial lining has specialized cells called synoviocytes. And those synoviocytes produce HA and lubricin. They also help with regulation of what's going on and communicating throughout the body and the immune system and the immune response of what's happening when these joints become overworked or overused or even injured. And so when that structure becomes compromised, that's really where the cascade of osteoarthritis begins. And it goes from synovitis to capsulitis. So you have your synovium, you have your joint capsule, and then you have your cartilage structure, and in between that is your joint space.
Meg, I'm glad you started with the synovium, because I think all too often we're constantly focusing on the articular cartilage. I always look at articular cartilage. If we do everything else right, the end result is healthy cartilage. But the problem typically does not start with cartilage. And for just a quick review for those that didn't hear that other podcast, the nourishment for articular cartilage comes from the synovial fluid or the joint fluid. The healthier the joint fluid, the healthier the synovial fluid, the healthier the cartilage.
Correct.
That's made by the synoviocytes. So, to borrow a famous line, save the cheerleader, save the world. If you save the synovium, you save the joint. Healthy synovium produces healthy joint fluid. Healthy joint fluid makes healthy cartilage. Healthy cartilage, healthy joint fluid, healthy synovium, healthy joint.
Absolutely. And I think that's one of the key things is that we have for so long, when we think about how we go about treating these cases and in managing osteoarthritis, is we've been so focused because we didn't have necessarily the tools in our toolbox to really affect the structure.
True.
And so I think, when we think about how we've utilized steroids and hyaluronic acid, and now with the orthobiologics and stem cells and things like that, there's so many different options now that we have available. And I don't know about you, but if you confuse, you lose.
Yes. And it is an easy, the thing is if you kind of go back and look at the history of joints, forever we had steroids and HA. Back in, around 2006, 2007, this weird product hit the market called IRAP. Mm-hmm. It was probably one of the first orthobiologics to hit. And that was option number 2. Well, let's go back 5 years. In 5 years, we've had ProStride, we've had Nultrax, we've had Arthramid, we've had stem cells, we've had a host of amnion products. So in 5 years, there's been a lot of things hit the market. And I agree 100%. It is easy to get confused. And when you do get lost in that confusion, you get lost or you lose. So I guess that's what I'm excited about today is we're going to take a deep dive into one single product. And like I said, having that base understanding, like today's going to be all about synovium. All about synovium. So this is what makes the joint work, the synovium. So for listeners out there, you're going to learn more about the lining of your joint and more about synovium than you ever thought you wanted to know. But it's going to be pretty cool. So
when we think about the synovium, and let's just start with the basic lameness exam. Mm-hmm. When we look at these horses and we start to work them up and that kind of thing, one of the first things that we do is flex those horses.
Right.
And I think one of the things is why do we do that? What are we looking for in those responses? And one of the things that we're looking to see is, is there a fusion? As we palpate the joint, we're looking to see if there's a fusion or swelling within that joint. We're also looking to see what the range of motion is in that joint. If that joint capsule is tight and we have a decreased range of motion, what does that have an effect? But also we're stretching that joint capsule.
Absolutely. And that's a great point because the nerve endings actually live inside that joint capsule and inside where that joint capsule inserts in the bone. And so when you flex it, you're absolutely right. You're actually pulling on those stretch receptors, and that's where the pain's coming from.
And I think when we think about that, so as a result of that pain, there's nerves within that synovial lining, mm-hmm. and that are tied in there. And so you have the response that ultimately happens develops into synovitis, so inflammation of the synovial lining. And to be able to manage that early on in the process, we have to delineate exactly what's going on. And so the tools and resources that we have used historically, when it comes to like doing radiographs, mm-hmm. And now ultrasound, I think now more than ever, we're realizing because the synovial lining is what? It's a soft tissue structure.
Right.
And so when we look at it from a historical perspective, I can remember when we were first learning, what was the first modality that we always pulled out?
Get your x-ray machine out.
Exactly. Well, can you see a whole lot of soft tissue structures with that x-ray machine?
No, I mean, that was the thing. All you could really see with it is you could see a little bit of excess fluid in the joint. You could see a little opacity like that, but you weren't looking at it. Mm-hmm. And I think, that's one of the things you brought up, ultrasound. I love ultrasounding some of these joints because you can actually see what that joint capsule's doing. Like the stifle's probably the one that's most notorious for this is when you put that ultrasound probe on, you see that really thick joint capsule. You see those really thick synovium. It's really easy to see, really apparent because it's a big joint. And that's one of the things when I probably grab my ultrasound to look at joints almost as much as I grab my x-ray machine.
And I'm so excited that you said that because honestly, that's something that I find myself talking to veterinarians more and more about, mm-hmm. is when you think about radiographs, it takes 21 days minimum to see a radiographic change. Mm-hmm. So you're already 21 days behind the 8 ball.
Right.
Versus when you look at a ultrasound, that's real time.
Yes, that's today.
That's today. That's what's going on right now. And you can even see those changes within the cartilage and being able to see those irregularities and some of these enthesiophytes that you'll actually see as well on radiographs. So you just have to be looking for them and understanding, because it's just a different image that we're seeing, again, because it's real time and it's based off, sound waves. And so I think being able to see that, one of my colleagues that I've learned so much from recently is Dr. Cooper Williams, and he is an ISELP instructor. And, one of the things he says is he talks about a canary in the coal mine and, being able to fly around and be able to see. That's really what we're looking at when we look at these joints. And, understanding the anatomy and the structure is so key, especially when it comes to ultrasound, because it does look so different. But, I think as we start to utilize our ultrasound machines more effectively and really see, and like in your practice, I know that you do it, as part of your routine. And so I really encourage veterinarians to consider utilizing, even if it's just a fast scan to start with.
Right.
And it doesn't have to be a major thing, but if you're familiarizing yourself with normal versus abnormal and comparing right to left and really being able to see, you'll start to pick up on some of those changes.
Some of the ones that I can remember seeing is when you have a lameness and you've localized it, let's say to the fetlock region, either through joint blocks or through nerve blocks, you've got this localized that fetlock region. One of the things I see a lot is I'll start doing the ultrasound. Of course, we're going to scan those suspensory branches. And the cool thing is when you're scanning that suspensory branch, on the front part of the leg, when you get close to that sesamoid bone, you're actually looking at the fetlock joint capsule. And on the back side of the leg, you're looking at the tendon sheath. And so when I'm doing that scan of that suspensory branch, I'm also catching part of that fetlock joint. And it's kind of cool because you're looking at that palmar pouch back there, and all of a sudden you see this really big synovium. And you're like, hold up a minute, this joint is not happy. See, I've localized this area, but as I'm scanning, I pick up on that really thick synovium, that really thick joint capsule. I know then my joint's not happy, so it tells me, it's like, we can't just look at just the normal stuff you'd think about in a scan. We're just going to go look at a suspensory branch or the deeper superficial in the back of the leg. Like, all right, we need to go evaluate this joint. And we may have to go in and do some further diagnostics. We may have to say, hey, we need to come back in and block this joint separately. But you can absolutely see these things on ultrasound, and it will change. As practitioners use it more and more, I think it's going to change the scope of how we practice.
I couldn't agree with you more. And I think the other thing, as we think about these structures, is being able to, normalize, figure out what is actually normal versus abnormal. Right now, it's very subjective.
Right.
And so I think that's one of the areas of opportunity that we have in working with, radiologists and imaging specialists that can really help us to normalize that. And that's something that we at, Contura Vet have really started to talk about, is having, what does a thickened synovium actually look like in particular structures, and working towards something like that with the experts.
Yeah. So let's start digging into the synovium. We know that the synovium of this joint, and that's that lining of the joint capsule, it's making this joint fluid. We know that the healthier the synovium is, the healthier this joint fluid is. And that is the only nourishment articular cartilage gets. So cartilage has no blood flow.
Correct.
And so the only nourishment it gets is that joint fluid. And it's, I kind of think about it, if you're making healthy joint fluid, it's like that cartilage is eating a well-balanced diet. If you've got really unhealthy synovium, you're feeding it McDonald's cheeseburgers.
I think that's a great analogy.
You're not feeding this good healthy food. You're feeding it McDonald's cheeseburgers and taquitos. So you've got to, if you really want to take care of that cartilage, you've got to feed it an appropriate diet, and the way you do that is maintain good synovium.
I agree, and I think that goes back to how the structure is designed. So we have specialized cells called synoviocytes, and a normal joint has different numbers of layers, anywhere between 4 to 6 layers of synoviocytes that are able to help produce that healthy nourishment and that joint fluid. But when the joint becomes compromised, you cannot replace those cells fast enough.
Right.
And so it's kind of like a leaky bucket is how I look at it in that synovium. And so you have these tight junctions that these synovium are aligned together. But when you have damage or inflammation that sets in, you start to degrade those tight junctions. And as a result of that, you get these inflammatory mediators or cytokines that start to become released. And as a result of that, that's ultimately what leads to that cartilage degradation over time.
Right. And, when we talk about synovium, different things can cause the depletion of synovium. Chronic osteoarthritis that's left unmanaged can cause it to be decreased. Certain traumas to the joint can cause it to decrease. And the other one is a normal aging process. As we age, we just don't produce synovium and as like we used to. And one of the things that limits performance in older horses is a lot of times maintaining these joints. And it's just because of the normal aging process. I mean, even if you look at people, an 18-year-old's joints, my joints at 18 were way better than they were now at 45. And that's how we can maintain these athletes better, if we can keep these joints healthier and happier. And when you really dig down into what that takes, it takes healthy synovium.
Absolutely.
So.
And I think when you think about it from that structure, what that structure does to maintain, that's really what I consider to be the source. And if you can continue to keep that source healthy and pure, then, just think of it as like, a water fountain. Like if you see a water fountain out there, it's nice, it's pretty, it's clean, everything looks good, but all of a sudden when that water fountain you start to see that brown water coming up and it looks gross. I mean, that's what we see a lot of times. I don't know about you, but when you actually go in and you tap these joints and you take a look at them, there's a big difference, even in the viscosity of the synovial fluid, is one that's healthy versus one that's abnormal and unhealthy.
I call it Goldilocks, right? You don't want it too thick. You don't want it too thin. You want it just right.
Yep.
And when that joint gets inflamed, it can go one of two ways. It can get too thick. It can get too thin. And our whole goal is like Goldilocks. We want it just right. So let's talk a little bit about Arthramid, what it does. And I'm gonna tell you, this product's been around in Europe since 2006.
2014.
2014.
For equine side, but it's actually was started in 2000, the year 2000, right. And on the human side, and it was initially for Arthramid, which was a facial reconstruction product. And over time, they decided to start to look at research for OA specifically. And that's where, looking at it, in 2009 is when the research initiated. And so looking at horses specifically to be able to utilize this product. And by the time it reached the market, really in 2014, to be able to utilize it and optimize it is really when it began.
Well, and I can remember when it did come on the market, we could not get it here in the U.S. And let's just say through some creative processes, we were kind of getting it over here anyway. And so I can remember using it, and I'll be real honest, as a practitioner, all I knew is it worked, but we didn't have the understanding as practitioners as to how it worked. And I can remember getting it over here, and I was like, okay, the last ditch effort, nothing else is working in this joint. I'm going to put Arthramid in it. And I started seeing results. But that's how we thought to utilize it. And we were thinking, as practitioners, because we didn't know any better, there wasn't as much published on it, we thought we were doing pure what we call viscoelastic supplementation. So this is the same reason we'd use like hyaluronic acid in a joint. We thought we were just making the joint fluid better, more cushiony. That was our original thought. And as you got involved with the company, and then the more research that's been done, the more we've learned, like that's not this product at all. It has nothing to do with that. It's really kind of cool, the mechanisms of action. So let's talk a little bit about how this product works.
Sure. So one of the things that's unique to Arthramid is the percentage of polyacrylamide in it. And the percentage of polyacrylamide in Arthramid Vet is 2.5% polyacrylamide. And it's based on a cross-linking pattern and the density of the cross-linking. And so there's up to 11 different types of polyacrylamides, and, with different percentages, if you will. And so when we think about, those percentages, a higher percentage doesn't always mean that it's better.
Yes, and in fact, there is another product on the market that is a higher percentage. And our initial thought with Nultrax was, well, it's a higher percentage, therefore it's better. We've learned now the only thing that makes those two products similar is they're both polyacrylamides. They work in completely different spots. We're not going to get into Nultrax today. But the 2.5% makes it work in a completely different location, this joint, and have a completely different mechanism of action than the bigger one. So just because it's bigger doesn't mean it's better. In this case, it's bigger, so it targets something else. And so let's talk a little bit about this 2.5%.
So when you look at the 2.5%, it allows for bioavailability. And that bioavailability, you inject it into the joint space like you would any other intra-articular injection.
Right.
But the unique aspect of this is it actually starts to integrate into the synovial lining. And by day 14, it's fully integrated. And so there is no more concept of that viscoelastic supplementation.
Right.
There may be a short window of time where it works as a viscoelastic supplement, and that's usually in that first 2 weeks. But after that, it's integrated into that synovial lining. And as a result of that integration, what happens is you are developing what's considered to be a bio-scaffold.
That's the coolest thing to me. That bio-scaffold, when I learned about that, mind blown. This is cool. Keep going. Sorry, I'm getting a little excited. I get excited about this product. Sorry.
No, I love it. I do too, honestly, because it's such novel technology.
Yeah.
And it's amazing to see how this product can really change the structure. And so the way it works, as we talked about earlier in this episode, we talked about those tight junctions.
Right.
And those tight junctions, what this product is allowing for it to do is actually basically restore that.
Right.
But as a result of that, we see increased number of synoviocytes on a histologic level. So it's not something that you're going to see from a macroscopic level, but from a histologic level at which we're going to see, numbers of cells being increased. So if you've got a normal joint that has synoviocytes 4 to 6 cell layers, what you may end up is you're going to help to restore it back to that 4 to 6 cell layers, but also in some cases it may be a little bit more, but it's not going to compromise the joint health. The other thing is we have to think about, where we put that. When we put Arthramid in today, we know that OA is a cyclical disease, and it's something that we can't stop. Like once it starts with the synovitis, capsulitis, osteoarthritis, it's ongoing. What is inflamed today in the joint, we could actually manage and treat effectively in the synovium, because that's what the target tissue for Arthramid is, the actual synovial lining. That's what our target tissue is. And if what you just said earlier, which is, save the joint, save the synovium, save the joint. And I think that right there is so key to what this product does.
And let's go back to this bio-scaffolding a little bit. When I'm trying to explain bio-scaffoldings and how this works is, if you want to, I guess my mind always goes to oysters, and a lot of people, I'm hoping this analogy works, but oysters, they have to have some place to grow. If you don't give them a place to grow, they won't grow. And so I always think about that bio-scaffolding is like the support structure that allows an oyster to grow. I love oysters, so that's why I guess this is important to me. But if you give them that scaffolding and that oyster finds a place to attach, it can grow and do something productive. And it's the same thing as bio-scaffolding actually encourages regrowth of synovium. And I guess why that's so groundbreaking to me is I know that as I have arthritic changes, I lose synovium and I don't get it back. I know that as this joint ages, I'm going to lose synovium and we don't get it back. And now we've got a product that helps us get back. And so that's by putting this in, having that bio-scaffolding, getting those synoviocytes to migrate and start to regrow, we can actually reverse some of the changes that have happened because of OA in the joint.
Absolutely. And the other analogy, I think, to your oyster one is that even maybe a little bit more when you think about structure is, it's spring season right now. We're getting ready to start planting gardens and things like that.
Yeah, got my seeds in.
Yep. And so you think about like a tomato plant, and we put those tomato cages around. And why do we do that?
It's a trellis. You got to get them off the ground and get them to grow.
That's right. And so you've got to give them support.
Yep.
And so basically that's the same concept that we're allowing for that bio-scaffold to create. And, and I think if you can understand that, then, it really helps to affect the structure and then returning that joint back to homeostasis. Because the body, as we both know, always is seeking going back to homeostasis.
Yep, homeostasis, normal function.
Absolutely. And so if we can get it to return back to that, then everything else will fall in line.
Yeah, the whole point, the joint will manage itself. We just have to get the tools to get it back on track so it can take care of itself. And that's absolutely what this product does. So,
and I think the other part is that looking, and I would ask you, in your experience and your clinical experience, when you inject this, and from your initial time you inject it until you come back and reevaluate that horse, is looking at that range of motion. What do you see in those horses as far as that's concerned?
And that's interesting, because when we talk about synovium and we talk about that joint capsule, that chronic inflammation of the synovium, that chronic synovitis leads to that capsule getting inflamed, leads to getting thickening, and we do reduce that range of motion. And I do think that plays a large role in how these horses function. And what I would say is, like, when these horses I work on that have had Arthramid, you do see an increase in that range of motion start to develop. And the biggest thing that I've heard we're putting it in, and I think this is the number one thing I hear, is like, is it possible for them to be more sound? Like, we've done a regular injection and they're sound. But then it's funny, you get to that 30-day mark, and they're like, he's actually more sound. Like, he was sound at 14, because we'll talk about this. We typically put a little bit of steroid in with I put in a little steroid with my Arthramid. So I get that initial effect with the steroids reducing the inflammation in that synovium. And that's going to happen somewhere around between day 7 and day 14. And so then they're sound. But then what I hear from my riders is we get out at 30 days and, like, he was sound at 14, Dan. But here at 30, he's more sound. And I think that's definitely coming from that increased range of motion in those joints.
Absolutely. And I think to that, because it takes time. And one of the things I think that I speak to veterinarians as well as horse trainers alike is this is something that it's not going to be necessarily a quick fix. It
Right.
does take time to integrate. And we talked about up to 14 days, and it will get even better over time. So kind of like a fine wine, if you will.
Yeah.
It gets better with time. And so I think understanding, and setting the expectations is key for your clients. And if they have more of a downtime, in their season, that is an ideal time. Doesn't mean they have to be out of work by any means.
No.
Because we have research that has shown that, what we recommend is that, they rest, they're injected, have stall rest for 48 hours, and then they gradually return back to work. And so that has been shown in multiple studies. So I think being able to know that, but also, like anything, if we can take, an athlete out of work for a little bit of time, allow the body to, heal, then ultimately the outcome is better versus just keep on pounding and going over and over.
Well, and I typically do 3 days rest, the day of the injection plus 2 more, similar to what y'all are saying. We do that, but then that's really the only restriction I've got. 2 days light work back into full, and I do the same thing with Arthramid. So the downtime to me is no different than the downtime with a regular injection. I typically get that better response. I get that other response at 30 days where they quote unquote get more sound.
Sort of like the longevity of it.
The longevity, and I think that's really what I see is a greater longevity. And the other thing that we talk about is horses treated with Arthramid. You've got good days and bad days on every joint, but the bad days aren't near as bad. So I don't, because you want to get to a joint before you actually have a lameness. You want to get to it when you're having a little bit of a decrease in performance. You don't want this. You don't want the disaster when you're going to the joint. We want to get into that joint before we turn into disaster land. So before they start limping, that's where we want to be, and that's where the flexion tests come in. But what I see is the bad days aren't near as bad as they were, and that's one of the biggest things I see. Like they don't tend to get as lame, or their performance isn't decreased as much as it is with a typical injection runs the course.
So I would say that's exactly what Dr. Mark Kuhner, one of our advisory council members that is over in Germany, he talks about that. And a joint that has Arthramid in it is much easier to manage than one without it.
I'm going to agree 100% with that. 100% with it.
Yeah. And I think just from the athleticism of these horses and what the expectation is in these horses, the sooner you can start thinking about this product as a first line of defense,
right,
versus using it as what you said, what we started back in early 2000, like an end stage. If it can work on this, then we'll see where it goes. And that is another thing when we think about Arthramid, it's labeled for all stages of OA, and so OA starts with synovitis. And if this is the target tissue, the earlier in the disease process that we can start to utilize it and manage it, then you're able to prolong the longevity of that horse's career and being able to continue that, well into their, 20s and things like that. Because I know as well as you do that right now trying to, reinvent and reinvigorate these ponies and things like that. My daughter being one that's showing right now. It's like you got to keep these unicorns going, right?
Well, and I can remember, and I think about this a lot, and I mean, Meg, you grew up riding. I mean, a 20-year-old show horse did not exist.
No.
A 20-year-old horse you had a really old horse. Mm-hmm. And now I've got a lot of 20-year-old horses that are still competing, and they're still happy to compete. Like the thought, like you can actually see it, and I'm like, whoa, my job is to go to the horse show. Why am I not going? Mm-hmm. Like they still like their jobs. They still want to go. And now we've got them working well into their 20s. And one of the keys I've seen with that is taking care and managing these joints early. And like I think it was a great point. And I give Gabe Brown, he's a regenerative ag guy. And I love his saying. He said, you don't have to change how you think. You got to change how you see.
I love that.
You got to see things differently. And so that's what I look at with Arthramid. We got to see things differently. And just joint health in general. It's not changing how we think. We got to change how we see. And this is a fundamental shift that is really happening in the veterinary world right now. Is we're having to change how we see. Because for 40 years we had steroids and HA. We're having to change 40 years of thinking. So when we're looking at these products like Arthramid, they first come out and we're like, okay, nothing else has worked. Last line of defense, put this in. Now we're having to change how we see and go, well, if it works then, why are we not doing it sooner? When the house is on fire, we go grab this. Well, what if we bring this in when just the kitchen's on fire? And we don't lose the whole house.
Exactly, absolutely.
When the frying pan's on fire, why don't we grab the water hose now, not when the whole house is inflamed?
100%.
So that's how we're having to change how we see. Mm-hmm. And I think that's what I love about Arthramid is I actually think that product may have brought that to light.
Well, I think it did, but I also think up to this point, we've never had anything that could actually work on the structure.
Right.
And that is the thing when I think about steroids and HA, and even some orthobiologics to that matter, is that we're really looking at, symptom modification.
Right.
And controlling inflammation, replacing, viscoelastic supplementation with HA and stimulating those synovial sites to produce more HA. Mm-hmm. And so now we actually have something that can help to affect the structure. Mm-hmm. And to me, as with anything, like thinking of a house and a foundation, if your foundation is crumbling, that structure is going to fail.
And that's a great point, because I do think Arthramid gives us that foundation in the joint that we can build off of. It's almost like when I've got that there, it's like, okay, I almost think my orthobiologics work better. I think my normal steroid and HAs work better, because I'm not saying we have to Arthramid that joint every single time.
Right.
There are times where we're going to follow up and repeat that. But I do feel like it gives us that foundation and allows my other modalities to work better in some cases.
Absolutely. And I think that's one of the things that we have learned over the years is that OA, as we both know, is a multimodal approach.
Yes.
It's not just a one-stop shop, one silver bullet, and this is going to fix it. And I think it's even taken us time as veterinarians to realize that, is that we were so used to try a steroid, try an HA, and then we saw that they work more effectively and synergistically together. Mm-hmm. And so that enlightened us to think about, okay, what can we do? And then we got other NSAIDs in the market and seeing how that can help to maintain, them as far as their soundness and being comfortable and that kind of thing. So I think as we look into that, and we've had other modalities and just, whether you do, alternative modalities, whether it be laser therapy, acupuncture, those are all things that we can do to keep these athletes in work. And so this is just one more tool in your toolbox.
Right. And I think that goes back to what we talked about at the beginning. Is forever we just said your horse has arthritis, and now again changing how we see, we're having to say, okay, well, why does it have arthritis? The X-ray taught us that it has arthritis because we have a chip in the joint, so we got to get rid of the chip if we're going to get rid of the arthritis. So the X-ray machine taught us that. The ultrasound has taught us if we don't change how the synovium lives and we don't change what's going on with the synovium, we're not going to affect the joint. We're not going to treat the joint. So I think, again, going back to how we see, and it's requiring a shift in thinking and seeing and understanding and thinking like, all right, my joints are arthritic, but why?
And I think that's a great point, because sometimes we'll see radiographs and they're completely clean. There's no change. And historically, when we see that, what have we gone to?
Grab a
steroid to control that effusion and that inflammation. But when you do that, are you doing anything for the actual structure of what's causing that?
I mean, that's the deal. I mean, you reduce the inflammation, which does help the joint overall, but at the same time, it's not changing the structure of that synovium. And I think that's why the two complement so well, is because you've got that initial anti-inflammatory in there, and then you've got the Arthramid that's like, hey, let's go fix the structure behind this.
Absolutely. And that's one of the things, too, at Contura Vet that we are very passionate about is research and development.
Yes. Y'all done, let's talk a little bit about, y'all did the safety study of using betamethasone concurrent with Arthramid.
We did. In conjunction with Dr. Bo Whitaker and some other colleagues, we utilized 10 healthy horses and evaluated utilizing betamethasone, because it was something that I was getting routinely asked. Can I use steroids with the product and do it safely and effectively? And so we developed a protocol and actually just had the paper was published last month in JAVMA specifically. And so we're really excited to have that information. And so really just in 10 healthy horses, we injected them in their fetlocks, and there was no adverse events that were associated with it. But it allows for you, and what I've heard from many of our colleagues is sort of that 1-2 punch, if you will. You can control that inflammation at the same time as being able to utilize Arthramid with the betamethasone in combination. It's not one of these things that, I say that you have to do it always in combination, but given, your clientele, how often you might be able to see that horse, I think it's something that you can certainly, utilize and know that it's okay to do it safely. However, if there is a great deal of effusion, or you may have some type of metabolic disease, in those situations, you may want to consider utilizing an orthobiologic as opposed to steroid. At this time, we don't have specific studies utilizing orthobiologics and Arthramid, but I can share with you anecdotally, I know that they are utilized, either in combination or in separate, whether you may go in with an orthobiologic initially to control some of that effusion and inflammation in the joint, and then come back in 2 to 3 weeks and inject Arthramid. And again, that's that same process. If you can get that inflammation down, it's a lot easier for that bio-scaffold to integrate into that synovial lining.
And I've done that a lot. Because one of the things we do know is if that joint is too inflamed, if we put Arthramid in, it just doesn't get to where it needs to be. And like I said, if we've got these underlying metabolic issues that I can't use a steroid, I will grab that orthobiologic, put that into the joint and say, hey, we need to see him back in about 3 to 4 weeks, and we're going to get the Arthramid in. And the two really, I think that's what I see is like the synergism with Arthramid and some of the other products is pretty amazing. Because like I said, it does its own thing, but it plays really well with others. Like it's a pretty cool product that way.
Yeah.
So y'all have got another study coming out. I'm a joint nerd, and Meg had me at the words gene expression. We won't get into the whole deal, but we're just gonna say I've got another study coming with Colorado State University.
We
Is that correct?
We do. It was a pivotal study for us that was started last summer, and it was a 70-day study. It was with the traditional carpal chip model.
Love that model. Y'all probably heard me say this before. You want to prove a product, you want to test a product, you need to do a carpal chip model. That's the gold standard, and I've said that 100 times. Like, that's the gold standard. That's the data we want to see, and y'all did it.
We did, and so we're in the process right now of analyzing the data, and so we'll hope to have that later this summer and be able to share some of that information, likely coming up at AAP this year. So just hang on tight because it's about to roll. And with AAP being in Denver, Colorado this year, we're pretty excited because, as we both know, CSU is just up the road from there. And so I think that what you'll find in this study is it's going to be pretty fascinating. We also did some a la carte options with this particular study that were some additional things that were on top of the carpal chip model, and so that were really interesting for us. And so some of that information, including what you just said, was an RNA gene sequencing, and so that was looking at inflammatory cytokines and what is actually happening with serial sequential draws of synovial fluid over that 70-day period of time, and being able to analyze that data. We also looked at a multiplex test to be able to see what the cytokines were happening and that kind of thing. And we were looking at specifically end stage, like what does it look like at day 70, doing arthroscopy at the end and be able to evaluate those joints and really taking a look to have that information. We also did nerve staining as well to be able to see if there's any changes, specifically in these nerves, because there's some thought with regard to that there is it blocking pain? We've seen it in goats where it has not, but we wanted to make sure that we had that information in the data. Same thing on the human side. So, I think being able to have this information because of the impact that the carpal chip model has made, not just in the equine world, but also, in human health. And so this study is one of those that has really allowed for that one health concept to be able to be shared. And so, we have sister products too, to this product. And so Arthramid is a sister product to this. And, being able to utilize some of the data that we will receive from Arthramid on the veterinary side will also help to, show information to Arthramid on the human side.
Now that's really cool. And like I said, if you want to know if your vet's a nerd, ask if they get excited about a study like this, because I'm a nerd. I'm pretty excited. So
yeah.
But no, it's really cool. And y'all also got you've got Arthramid, but you've also got another product that is now launched in 2025 on the canine side. So
we have with regard to. It's a dual species with Arthramid, and so basically utilizing it as a targeted therapy. So if you have dogs, and I've yet to go to a barn that doesn't have some dogs running around it. I don't know about you, Dan, but for me, I've yet to ever go to a place that doesn't have a dog or two running around. And so this product is now something that can be utilized specifically in dogs as well as horses. And so we're really excited, me included, that to be able to have an opportunity to start to change what I've seen in horses, start to relay that over to our canine patients is super exciting. And it's funny because working in a lot of barns, obviously a lot of dogs, and when you're working in barns with horses, joint injections are a very frequent thing. It's almost like Coggins tests and vaccines. It's just one of those things that happens. In the dog world, this doesn't happen. Like, you hardly ever see it. And I'll actually get approached by some of my equine clients and like, hey, my dog's got a bad joint. Why can't we just inject it like we do my horse? And I was like, well, glad you brought that up. Let's talk about Arthramid. And I've actually done quite a few dogs with Arthramid, and I can tell you it's pretty cool because you see these dogs a lot, and when you pull up and like, yeah, it's a bad day, he's not getting around like he used to, and you kind of, he's moving a little bit slower, and then you're back out there a month or two later after you've injected him, and you're looking over and like, where's he at? And like, oh, he's probably chasing something somewhere. He's got a whole new lease on life. It's kind of cool. Yeah.
It's kind of cool.
And I think that's the mindset that we, really want to change, is that we have seen the benefits in horses for so long, but also now that we're starting to see it in our canine patients as well. And that's something we're super excited about. We've got, a study going on right now, even in canine, for a 12-month efficacy study in elbows, because elbows in dogs are the number one joint, because it's so hard to do any type of surgery on the joint. And so to be able to maintain those joints, it's really a challenge. And so this has been a game changer. And so the gold standard really for, to see how effective this is to look at a 12-month study. And so we've got that study will conclude at the end of this year. Dr. Matt Brunke is our lead investigator in that, and he's a diplomat of sports medicine and rehabilitation for canine. And he's located just outside of Washington, D.C. And so he is an expert and serves on our advisory council, and has been such an advocate for this product, and has been able to, put it into working dogs. Being there in D.C., you can imagine the types of dogs that he's putting it into. And it's pretty amazing to be able to see what's happening, especially in those working canines.
I can remember I got to meet Matt because I'd called Meg, and I was like, hey, Meg, these people want this in dogs. I can do the injection, not a problem, but I need to know the ins and outs. She's like, hey, don't worry, you're going to talk to Matt. Matt will tell you everything. I called Matt, fantastic guy, taught me through it, told me the ins and outs. And like I said, we've been really successful with it. You've helped me do some, and I mean, it's been, to me, it's another change in how we see, forever, if your dog was arthritic, here's some Remedil, and rest him, and he's just not going to be as active. Well, now we got to look at it differently. It's
taking that targeted approach that we've taken in equine for so long, and being able to start to apply it to our canine counterparts. And I think that's the difference. Is it's not something we as veterinarians learn in school as a standard of care. And that's one of the things that I'm super excited to be on the leading edge of that, is really changing that standard of care. We just actually left Western Veterinary Conference last week in Las Vegas, and we had 24 veterinarians from all across the country that came in and worked with our advisory council members. That included Dr. Matt Brunke, Dr. Patsy Mitch, Dr. Jen Repock, and Dr. Ariel Markley, which are all experts in that field. And it was just so fun to get to see them have the hands-on opportunity. And the feedback that we got, was they just wish they'd had more time, and if that's the worst complaint I have, then I feel like we've won, because that's how we all feel, I think, when we go to wet labs and we get passionate about something and excited. But being able to have this, as an opportunity for us to really be on that cutting edge. And, as an equine practitioner, I remember when I first went into small animal practice, leaving Rood and Riddle after those 3 years, to me, it's like, I remember being in a practice, and talking about a joint injection, and I might as well have had 3 heads when I brought that up. And so now to be able to say I wasn't wrong when I had that thought is something that can work, is super fun and exciting.
It's really cool because, like I said, I think, again, it's changing how you see, and we just didn't look at that as an option, and it's definitely an option. Definitely an option. And Meg lives not far from the clinic at all, so I kind of got I get the ins and outs, and she helps me with these things, and it's really cool to get to see the difference it makes in these dogs' lives.
No doubt. Really cool. No doubt.
So Meg, we're about to wrap up here. If there was, what is the biggest question that you get asked, as far as for our listeners? What's the biggest question you could ask her? What's the one thing that you wish they could take, you hope that they take away from this, and that you hope that hope they learn? If you had to boil all this down, and that's going to be tough, but I'll give you two.
Okay.
All right.
The first one I would say is, it's not the cartilage, it's the synovium.
Right.
And understanding that concept and knowing that is where we really need to start to focus our attention. And you can do that so much earlier in the disease process, and rethinking how you're doing your imaging. So like we talked about, radiographs and ultrasound. Ultrasound is real time, and implementing that more in your practice more effectively, and not just going for the big joints, not just a stifle, utilizing it in, a fetlock or a hock, and even your coffin joints, and being able to see what's going on with that synovium. Those are not structures that you're routinely ultrasounding by a lot of practitioners. I'm not saying that you're not doing that, but many of them don't. If I ask them, 9 times out of 10, I scan my stifles. Anything else? No. Okay, well, let's start, how many other joints are there? And let's think about it that way.
And I'm that fetlock, that's probably my number one joint to actually have Arthramid in. And it's because of the ultrasound machine. And people don't think about this, but that fetlock is the joint that makes a horse a horse. It functions different. It functions in extension. And without it, the horses can't pee off. They can't jump. They can't run like they do. Like, that's the joint. That's my favorite one. Love the fetlock joint. Love everything about that whole area. And it's absolutely, when you start evaluating that with an ultrasound, you see a whole different world. So.
And I think the second thing that I get asked the most about is, really, where's the target tissue? What exactly, where does this work? And going back to what we just said, is understanding when you're doing joint injections, what does this work on? And to me, specifically knowing that Arthramid works on the synovial lining and creates that bio-scaffold to allow for that joint to return back to homeostasis. A healthy joint starts with a healthy synovium.
Save the cheerleaders, save the world, save the synovium, save the joint. I'm telling you, it's save that synovium. So, absolutely. Dr. Green, thanks for being here today. Look, guys, thank y'all for tuning in. We love your support. Y'all keep sending in ideas. We're going to keep doing more and more of these. I know y'all keep sending them in, and we're trying to get to all of them, but it's going to take time. But please don't stop sending your ideas. We really do love this. We love bringing people in. Big thanks to Meg for being here today.
Thank you for having me.
You can DM us. Meg's rolling her eyes because she knows I can barely use a cell phone, but you can DM us, you can Facebook us, you can call us, send a text, email, carrier pigeons. I think that's the next one. We had one vet, she'd never gotten a mailed letter, and she got 3 mailed letters. We're working on getting that swag out. She actually got her first letter in the mail from our listeners, and it was really, really cool.
That's fantastic.
So now I think we need to go for a carrier pigeon. So if anybody out there's got a carrier pigeon and you want to send it via carrier pigeon, that'd be really, really cool. So, but thanks for tuning in. We really appreciate it from all of us at Countryside Equine. Hope y'all have a great week. Thanks.
Bye. Thanks.